Hello, everyone. Welcome to another Journal Club. Tonight we have a very, very special guest with us to discuss vestibular rehab for patients in stroke and neurologic diagnoses. And our guest is Dr. Christina Garrity, an awesome physical therapist and geriatric specialist, and one of the best, I think, treatment idea developers that I have seen. And I do not say that lightly because I've known quite a few awesome clinicians. So I'm very excited to have her on. And I will let Christina additionally add whatever you would like to your introduction.
Sure, yeah. So I've been a vestibular therapist for a little over 10 years, mainly in an outpatient setting doing outpatient neuro. So started in outpatient neuro, quickly transitioned into vestibular rehab with different certifications and saw how closely those two really blend together. And so this is a huge passion of mine to talk about the overlap and how we can take vestibular exercises and vestibular rehab and apply them to our everyday practice with neuro patients. We'll get into that more with some video explanations and examples as we go tonight.
Fantastic. All right, well, we're going to dig right into the article that we had set forth for part of the Journal Club, which is Vestibular Rehabilitation Therapy on Balance and Gait in Patients After Stroke, a Systematic Review and Meta-Analysis, which hopefully means that's the best, newest data we have available. This was published in 2023, so it's pretty fresh. So I always like to start all of our talks with a really super quick, basic, get everyone on the same page. So our vestibular system, inner ear balance system, and that we have one on the left and one on the right, and that sends information to our brain so that it can process that information about where we are in space, and it integrates that information along with our body sense information or proprioception or somatosensory, I've heard it lots of ways, as well as information from our eyes, our vision, and even information from our hearing and also our past experiences. So there's a lot of stuff going on with the brain. The brain is awesome. It is wonderful. I always like to tell my patients it's a beautiful learning machine. But certainly, unfortunately, like any part of our body, it can have challenges. And one of those challenges is stroke. So a stroke is considered to be cerebrovascular accident, or CVA, you'll also hear it called. And it is either a clot or a bleed in our vascular system that is providing blood supply throughout the brain, as all parts of our body need. And unfortunately, when that happens, there is some sort of usually disruption and possibly damage to some of those nerve cells that were served by whatever part of the vascular supply had issue. And so there is really a huge array of presentation with stroke because it all depends on how bad, quote unquote, how bad the clot or the bleed was, how many areas were affected. Was it one side or both sides of the brain sometimes? Is it kind of the back part of the brain called the cerebellum? Lots of different considerations there. And, causes of these clots and bleeds, again, can be many and varied. Everything from something like we'll have a long-term issue like vascular or heart issues, so we weren't getting good flow, to side effects from medications. Certainly certain birth controls, for example, have been known to occasionally cause stroke. So it's really a kind of a big consideration because there's not really just one group that gets stroke, is what I'm trying to say. And so even though it's kind of, maybe we might think of somebody who is maybe a little older or not as healthy, we actually can see stroke in other folks who do not present that way. So it's important to me to keep that in mind when we think about what kind of patients we might be seeing that have had stroke. And for those of you who are not aware on this talk, which most of you hopefully are, vestibular rehabilitation is an exercise-based therapy that is designed to promote gaze stability and facilitate sensory integration for patients. This is big because I think sometimes when people think about vestibular rehab, they're like, oh, there's clearly a problem with the inner ear itself. Crystals are out of place, that's BPPV, or there's been damage to the inner ear, that we might call that a vestibulopathy or hypofunction or loss. But actually, the areas of the brain that utilize vestibular information and process that information and help integrate it, those are all still part of, in a broad sense, the vestibular system as a function. All right. So this is why it makes some sense, potentially, that some of these activities that we would traditionally give to a patient after something like a vestibular hypofunction or loss or vestibulopathy, however you like to call that, might also be able to be applied. Just the way that even if I might hurt my shoulder, I'm going to do arm exercises. But if I also get a stroke that affects my arm, I might also do arm exercises, right? So there's definitely overlap that way. And we're trying to change the nervous system through inputs, but that still can work that way. So this present systematic review was trying to see if the effects of vestibular rehabilitation, in addition to what they call usual rehabilitation, compared with the just usual rehabilitation, could improve balance and gait more so after stroke. And they looked at a bunch of randomized controlled trials, which are considered to be the strongest evidence overall, well, other than meta-analyses, but as far as individual trials go. So they included trials if the participants were diagnosed with stroke, which seems pretty clear that that was their focus. And then also if they had verified impaired balance and gait due to stroke for the participants in those individual studies they looked at. And they excluded studies if there were neurologic or orthopedic problems unrelated to stroke that would affect postural stability, which makes sense. They're trying to be kind of more pure about what the vestibular rehab could be helping. They also excluded folks who had balance or gait impairments prior to the stroke, and they excluded those who had visual field defects. So the vestibular rehabilitation that they were looking for to say, okay, this could be included in our meta-analysis, any RCT or randomized controlled trial that had gaze stability exercises, which they were abbreviating interestingly as GSE, which I guess was convenient for that study, but I had never seen that abbreviated that way, so that was interesting. Eye and head movements, which I will tell the group out here, I have heard those also called active eye and head exercises. I've heard it called 2 targets, and I've heard it called gaze substitution. But I am pretty sure they mean the same thing, which is when we have 2 letters written on Post-it notes or something like that, the person will move their eyes towards one and turn their head towards one, and then their eyes towards the other and their head towards the other. And that can be done vertically and diagonally and all sorts of things. So it is a strategy that can be used in traditional vestibular rehab. I would say it's often used for bilateral vestibulopathy or hypofunction. I have found it very useful post-concussion because it's kind of working on a combination of saccades and integrating some head movement for vestibular stimulation, if you will. They also involved kind of where there was a lot of specific head movement type activities, so randomized control trials that had those, because we know that for patients who can't follow enough directions to really do kind of proper gaze stabilization exercises, you can get a lot of good effect for the vestibular system just by stimulating frequent head movements, like, oh, I want you to, look for the different colored balls or whatever, you name it, some sort of motivation, hopefully, or a way to get head movement, particularly active head movement, if you could get it, as opposed to passive, although there's some argument for that as well, is better than nothing. Then they kind of used a broad term called vestibular stimulation, and then specific exercises or techniques to enhance vestibular function. So we're going to assume there's some kind of movement, up, down, sideways, rotation, where that's all going to stimulate the vestibular system specifically, as opposed to walking maybe, a couple steps forward, back straight. That would be limiting, not a lot of vestibular stimulation there comparatively, right? Usual rehabilitation, they were talking about in an appropriate way, customizing your rehab. So if the person has a lot of issues with leg strength, you're going to work on leg strength. The person has a lot of issues coordination, you could do coordination exercises for a limb, things like that. So that's your usual rehab group. And again, the people who got vestibular rehab were also getting usual rehab, but that way it's really the only thing you've added, right, is for the vestibular rehab. So let's just see if that adds additional benefit. So there wasn't anybody getting nothing, which is always nice for that group, right? All right, so this meta-analytic study ended up including 15 randomized controlled trials with a combined 769 patients. So that feels like a pretty good number to get some information. And they felt that there was a moderate certainty overall, and they ran a bunch of numbers, which I admit I did not analyze. I'm trying to trust their statistics, but I could ask my sister, his statistics professor, to double check them and see what questions she would have. But be that as it may, it looked like there was moderate certainty of evidence that vestibular rehab could indeed improve balance and gait in patients after a stroke. And they did find there was a bit of a time importance. So particularly when it's integrated within 6 months, and the best outcomes if they'd started that within a 3-month time span of having had the stroke. So this is consistent with other literature as far as, other kinds of rehab also having best impact earlier on. It does not mean that we can't make changes later, but just they're looking for like kind of bang for your buck, I like to say. So they really want to see, kind of a stronger outcome or kind of faster results, things like that. Then we are trying to work in that time frame where the brain seems to be, most ready for change overall. And they felt that the most effective vestibular rehab protocol, if there's such a thing, is to improve balance after stroke, was gaze stabilization exercises, which I'm sure were used in almost all the studies, because again, that's like kind of a staple to stimulate the vestibular system, which is fine. As well as swivel chair training, which was news to me, and I was intrigued by that, followed by general head movement, and then gaze stabilization exercises or activine head movements. And they wanted a certain duration. So if you only did it one time in one session, you're probably not going to get a lot of additional gain, which makes sense, right? You want to do it repeatedly over a 4-week period. They didn't say which study. I'm sure it was an array, twice a week, 3 times a week, that kind of thing, depending on the study. But, hopefully a reasonable rate of duration frequency. So I did find a video that was put up by PhysiTrack, which is a home exercise program online, showing a swivel chair exercise. So I put it in here for everyone to see. So they described it as literally having the person sit in some sort of swivel chair, having them close their eyes, rotate the chair 3 times, so a full 360 times 3, and then stop, and then keeping the eyes closed, wait until the dizziness resolves if there is any. The goal is to have resolve within 15 seconds. If 3 spins is too much, you can back it off to 1 spin, etc. So it is essentially, the way I would think of it, a sort of habituation. So we're trying to kind of expose ourselves to some movement that might create some kind of challenge or give us a little bit of potential symptom. And then, try to teach the brain to process that movement better with little doses over time, and then try to build up just like you would build up your weight if you're trying to get stronger. So that was interesting to me. So I always love when a study presents an idea. I did like it because it can be done seated, and I could picture finding a way to do it with a person in a wheelchair. So when I think about folks who are post-stroke, they can present with a wide variety of mobility at different points during their recovery process. And so it was nice to see, since we'd like to integrate vestibular rehabilitation early, that if there's certain activities that I'd love to do, but just the person's not ready for those yet, they're a little more challenging vestibular rehab exercises, we can start with something as basic as this, and that could create benefit. So that was pretty interesting to me. So kind of in the last part of this article, and then we're going to switch off to some nice case examples by our guest here. The vestibular system, we know it's involved with postural control, and we know, as we described at the very beginning of this talk, that it's integrating, that vestibular information needs to be integrated in the brain with our other sensory information. And then there's also this kind of feed forward system where the vestibular system has impact on what motor responses we get. So it's not just that the sensory system is sending information to the brain, but then that also has an influence as to what our body then might do, essentially. And so although it's easy to think of it as like, that first part of this picture, which is, the vestibular system sends information to brain, we got to think about what's happening on the output end, not only with those eye movements and can the gaze stay stable, but also, what body reactions or kind of body movement or, kind of orientation to center is perhaps responding or kind of coming out of that input, is what I'm trying to say. And it is also involved with many other factors, such as what's going on in the environment, but it's good to think about how, there's this whole relationship And, we could get real deep into the anatomy, which I do not intend to do tonight, but suffice to say, the article touches on how there's these different tracks, right? Our reticular system, all these things that kind of have to do with kind of stimulating of being awake and alert and interactive, our cognition, our ability to orient ourselves in space. There's some beautiful studies coming out on kind of the relationship between Alzheimer's and vestibular hypofunction and cognition. And, we're thinking about these things and how they, again, it all comes back to what's happening in the brain and how these different kind of inputs can influence one direction or another, how, other functions in the brain can occur either more or less effectively, and what can we do to help maximize for those who do have some issues. And, there's a lot of parts of the brain, right? It's easy to think about the cerebellum because that's right where the vestibular nuclei lives. Like, oh yeah, that's the part of the brain that would have to do with the vestibular system. No, there's like all these other connections is what I want to say, with the cortex, the thalamus, the hippocampus, the spinal cord has tracks, right? Even relationship to cranial nerve 11, which is like neck situation. So there's a lot of, kind of relationships happening, and ideally that we could potentially influence, right? So one of my favorite phrases is we're going to work with what we got. So when my patient's like dismayed because they have, let's say, a unilateral loss or whatever, I'm like, okay, we're going to how can we fill in the gap here? What can the brain do for us? What can our muscles do for us? What can, practice taking, a step for balance do for us? So there's so much that we can try to influence, even when there are deficits, whether that's from a stroke or a unilateral loss or what have you. So it does seem that overall vestibular rehab can help by influencing the central processing within that central vestibular nervous system, which could help to promote some neural recovery via neuroplasticity. So it makes sense to me. And I have seen it in action. So speaking of seeing it in action, we're going to do a nice little handoff, and our guest, Dr. Christina, is going to give us some cool examples.
Yeah, I love that you ended that segment on neuroplasticity, because I think that's really where this falls. And we talk about vestibular hypofunctions, and we're talking about compensation and adaptations and habituation to different stimuli. Those are all different forms of really neuroplasticity that's taking over for those peripheral losses. And so when we talk about taking vestibular rehab and applying it to this neurologic population, it's really no different. We're just trying to have a different outcome, right? We're not trying to compensate for a peripheral loss, but we're trying to maybe compensate or adapt for a central loss or something that's not firing as well in the central nervous system because of the location of a stroke or a brain tumor or an MS lesion. And these are very commonly dispersed throughout the cerebral cortex, the brainstem, the cerebellum, and as you just nicely stated, the vestibular system is integrated into all parts of that central nervous system. And so when we talk about doing our, gait evaluations and our balance evaluations in that population, it's really important to add some of these vestibular screens to head movement sensitivities and how does the balance change when we move the head. And if it does change, that's a huge trigger to us as PTs that we need to take some of these vestibular ideas and integrate them into our practice. And so the point of hopefully what we can help share tonight is how do we do that? What does that look like? And so I have 3 cases that I brought. We have a stroke patient, a brain tumor resection, and a Parkinson's case. So we'll just kind of share a little bit about each one. We talk about like the pillars of stroke rehab. I think from a PT standpoint, we're really trying to get patients post-stroke to walk more efficiently or move more efficiently, increase their speed of movement, and then create stability, right? With those 3 things, we can have a better successful outcome for locomotor function in this population. And I think where the vestibular rehab piece comes in is this stability piece. When we're talking about training balance, training locomotor movements in all planes, right? Because we can walk on a treadmill straight, we can walk down the hallway straight, but our lives aren't straight. They're right, they're left, they're up, they're down, they're distracted, they're constantly moving. And that's where this sense of stability comes in. And that's where I think vestibular rehab really has a crucial role in chronic stroke, acute stroke. I'm excited to see some of the new literature coming out. Like half of the studies, I think, in this meta-analysis were after 2018. So I think it's really the field is starting to catch up with like,
Yeah.
hey, what's happening with this vestibular rehab stuff? And maybe we should look at it a little bit more. So I'm excited to see what else comes out. And so just wanted a little plug, all the videos that are in today's lecture or case content were shared with permission from these patients that I saw in my clinic. And so this is our first case, chronic stroke, 2 years post-stroke, 75 years of age. About 6 months before seeing me, he had a sudden onset of movement-provoked dizziness. The physicians were like, maybe it was a stroke extension. He had an imaging that showed no change in his prior stroke, location, or size. And then they did caloric testing and it was normal. And so he's just like, today I'm dizzy. I don't know why. Still having pretty significant hemiparesis, walks with an AFO and a cane. I think his baseline gait speed's like 0.4 or 0.5. So he's not moving great, but he does what he can in the community. And having this new onset of dizziness is like very debilitating for his sense of security. Fall risk just skyrockets when you have this kind of unsteadiness. And so this is kind of how we approached that moving forward. So a little bit of a plug, since stroke rehab is a passion of mine. You know, when we talk about stroke, I'm rarely doing like this 5 minutes or 10 minutes is going to be vestibular rehab, right? Because there's huge intensity matters in this population. We're trying to drive neuroplasticity. We're trying to improve walking efficiency and speed. But how can we, in that context, add little pieces of vestibular and stability and head movement? And so in most of the videos, I think there might be like 3 exercises where they're just standing. Most of these videos really have people moving because I'm trying to drive intensity. So just because we are still PTs, we want to do our thorough evaluation, make sure, you know, what does the head impulse test look like? What was the DVA? We still screen for BPPV, you know, do our due diligence, even though the calorics were normal and MRI was normal. So this is kind of how he presented. His biggest thing was his DVA was impaired and a previous therapist had already given him ×1. So he had already done ×1 at home and standing on foam with his eyes closed every day for like 3 months, I think, by the time he saw me. And it really hadn't changed anything. And I think that's because we were addressing just vestibular. We weren't addressing stroke, right? And so like we need to treat the whole person and mesh these two things together.
And let's talk about DVA while we're here. So DVA, so for those who aren't as familiar, it's dynamic visual acuity. So this is a test where you have the patient read the lowest line that they can read on an eye chart from a proper distance for that particular eye chart with their head still and their usual correction of vision for that distance. And then we have them, or I like to do it myself, I'm kind of controlling, because I want to make sure the speed is proper. Their head is supposed to move at 2 hertz, which is pretty quick, and it's going left and right. And then they're going to start, I like to start them at least 5 or 6 lines above where they were when their head was still. And I'll have them start up at that line and read left to right, line by line, until it's too blurry to read is my instructions. So just kind of till I see them make a mistake, generally. And so the normal difference that folks would expect to have is a 2-line difference, meaning what they could read when their head was moving is going to be 2 lines higher than what they could read when their head was still. So we expect this to be abnormal in someone with a peripheral vestibular issue, particularly if it's newer. Often we can get it towards normal if it has had proper rehab, or just kind of over time, sometimes it will improve. If someone has a bilateral loss, it tends not to get completely normal. That's harder to get, I'll say. It's not impossible, but we're pretty happy with at least a 3-line difference is very close to a 2-line difference. To me, that's good. And if someone never gets better than a 4 or 5-line difference, but we can learn to compensate as far as function and balance, then that's okay too. So when someone says to me, Helena, there's nothing wrong with the peripheral vestibular system. You did a head impulse test, they were fine. They had calorics, it was fine. Clearly the vestibular system peripherally is acting fine, but the reality is that dynamic visual acuity in particular does involve central pathways. So, not to steal your thunder, but I just want to let everyone know it can be abnormal. And I hear this a lot, so I like people to think about this and be aware. I've had patients with MS where it's a 3 or 4 line difference. Usually it's not dramatically abnormal, like in a bilateral that's new. You'll see a 6 or a 7 line difference sometimes. But I'm not surprised if I see a 3 or 4 line difference in someone with some sort of central vestibular issue, because those central pathways could be impaired in a way that the ability to stabilize gaze is impaired. But it is true that in that case, not that doing gaze stabilization exercises is wrong, but by themselves, they may not be able to quite address the issue in the way that we usually expect it to do so for a peripheral issue. Did I capture that well? How we doing?
Yeah. No, it's good. Yeah.
Right.
So he was doing what he could, but it wasn't changing his dizziness. And I think that's because we weren't challenging the dynamic piece. We weren't challenging the intensity piece. And so let's see what we did.
Yes. What did you do?
And so in chronic stroke, there's a lot of research coming out on training intensity and speeds and using intervals. So you want to try and walk patients at a faster speed, reaching these higher heart rate intensities, but they can't always maintain that, right? So you might go high intensity for a minute or two and then back it back down. So I use those slower speeds as my vestibular interval. And so here, during a slower speed for him, I'm just having him count my fingers. Like, as long as it's so easy to not have to like go grab something when there's someone on a treadmill. So playing cards in your back pocket and your fingers and where you put your fingers. Maybe it's more in front or maybe it's diagonally if that's where their deficit or balance really throws off. Here we're still doing ×1, but again, he's walking doing it. Preferably, we would do no hands, but that's too hard for him right now. So we're still driving heart rate intensity while we're adding some of this head movement. And this is more, honestly for him, let me stop this for a second. Honestly, from him was more of a habituation standpoint. Like that movement to him was provocative. And over time, maybe we weren't going to change that because of the location of his stroke and whatnot, but we can still habituate the brain to tolerate that better. And so again, habituation is kind of graded exposure, pushing them to where they're like somewhat symptomatic. I like to go like a 3 to 4 point jump from their baseline. And then I think in a traditional setting, you may say, okay, go sit and rest and bring your dizziness down. But walking on the treadmill for him didn't make him dizzy. So I used his rest from dizzy as his higher intensity interval.
Yes.
So we push heart rate and then during the heart rate recovery, we push vestibular. During the vestibular recovery, we push heart rate, and kind of gets you the biggest bang for your buck in the limited amount of time that we have with these patients.
Yes. And you're doing 2 things additionally right that I want to say. One is, you've already described how you tailored your treatment to the individual. So I can think of a patient post-concussion, for example, where this wouldn't work because that they would be dizzy the whole time and it would drive up and up and up to where I like to say it's poking the bear. And the dizziness could be so much that the brain will not learn from the experience, and then it will be kind of a negative feedback loop. So instead, I might put that person on the treadmill, have them walk. Maybe that's enough right there. Maybe I do add a little bit of head turns. Usually I like to do something fun because there's something to that seems to drive down dizziness. And then we'll actually go ahead and take a break. But I like to do what I call a working rest. And so we'll do something else. And it doesn't have to be vestibular then. Maybe it's their head is still, and we're going to do some like reaching activity. So they're moving their eyes a little bit. They might start to move their head a little bit. They don't realize they're doing it, and it's in a different way that's not driving them up. So you have to, again, kind of, I call it read the room and try to figure out what's that Goldilocks level. And sometimes you're going to cross the line and especially in a concussion patient, I will say they might have symptoms like later after the session and you thought the session went so well. So that's a little tough, but I don't mind it because we're doing our best to say, okay, what is going to drive change? If nothing changes, nothing changes. This is very true for the brain. So that's why doing VOR even differently, like, okay, if they always did it seated or standing, like I want sidestep. We'll just take a sidestep right, a sidestep left if walking on the treadmill is not feasible for somebody. So I would not steal your thunder, but this is just a way to like, I love that you're trying to tailor the treatment to the individual. And the other thing you're doing is you're saying, okay, we'll try not to like waste any time. So very rarely will I let someone sit and do ankle pumps or kicks, but sometimes that's all I can get, then okay. But a lot of times, like people like laugh at me. They're like, why are you giving them like, people call them SSMP rows, like you put a band around the wrists and have them do like this. But pretty much everybody has some rotator cuff issue. And so many people with balance issues are really relying on their arms at times. I do want to eventually reduce that. But in the meantime, they should have strong arms because the last thing we need is for them to use a reaching strategy to regain balance and then hurt their shoulder. And you know what I'm saying? Like these folks are so prone to orthopedic injury and there's a lot of data on that. So I'm very aware that I can work on different things, and I'll say, okay, well, we give your legs a little rest. We're going to do this. And then, maybe seated VOR is somebody's like, if they're not very dizzy, but they are a neurologic patient, that's their like body rest, but then they have to work their brain a little bit if you wanted to go that route. So there's a lot of directions you go. Anyway, please continue.
No, that's okay. Like on that note, when you think about traditional clinic setting, like what if it takes a lot to like get stuff out and put stuff away and transition between these different things. And what if I need their rest for my own, to do what I need to do? And something that I've kind of learned throughout the years is that if you can pick like 4 solid exercises easily set up, and they each address different things, whether this is vestibular, intensity, strength, multiple directions or floor transfers, and you use those 4 core things that session as an interval. And so they're jumping from station to station. You're not having to set up and tear down a lot of stuff. You're repeating what you've already done, but in a intensity driven way, in a meaningful way. And it kind of creates, from a busy clinic setting and pace, some stability that lets you still feel caught up, whether that's documenting or whatnot, because you're not constantly switching to do different things. Like it's all there right there.
Absolutely. So. I love it. Okay, good.
Okay. So I think he's going to do a speed interval for a second. This kind of gives you a sense of his deficits. Like 1.3 for him is booking it. So he would not let me speed that up. So here's a slower 1.8 or 0.8. And now we're doing spotted cards. What kind of game can you create in this setting? And so for anyone who's not familiar with spotted cards, they're like 2 cards that have lots of different images on them. And each card that you put out is going to match the other card. There's maybe 1 image that's the same. And so they're constantly having to visually scan, and depending on where you put those cards creates the amount of head movement that you want, as well as the direction of head movement. So you'll see me, this is a simple setup. They're only about 12 inches apart, and he's just looking back and forth, trying to find the image that's the same. And you'll see me in a higher level patient move these in a much more challenging location to get greater head movements in a particular plane that I want for that patient. So spotted cards I have like 3 decks. They have different themes because I use them all the time. Okay, so then I think next, let's see what happens. Yeah, so there's another kind of research coming out that is looking at, we talk about gaze stability. And a lot of us think of that as ×1. So trying to look at a target and move our head back and forth in this way. And there's benefit to that. But there's also something called like treadmill gaze stability. And just walking on the treadmill has a bounce. And it's more of a natural bounce of your head that you would get walking every day. And so I frequently have these patients try and read on a treadmill because it's a form of gaze stability. It keeps their moving. I can keep their heart rate up. And then I like to do like word mazes, or there's like different play on words trying to solve the riddle, or I have jokes that are written out that I think are funny and some people don't. And then word searches are great. Word searches are great for a lot of different vestibular patients because there's a sense of busyness to it. And they're trying to scan all of this busyness. And so for concussion, this is a great cognitive task as well as visually stimulating task. Here, it was just another way for him to focus his gaze, kind of looking at that DVA deficit in a functional way.
And there's ways to change this again for the patient. So I'll have them find letters. So maybe it's a letter I say, okay, find an L. Maybe, in other words, sometimes reading is not right. And especially depending on, I'll just say cognition / like even education level. So you might have to adjust. You can even do shapes or something. So it doesn't even have to be reading. But the point is you can find different ways to have them scan and look and use their eyes, and probably sometimes have a little bit of head movement. And not just on the treadmill if you don't have one, or maybe treadmill is not right for that patient. I've had them do it on the bike because for some people that, just like on the rec bike, like the recumbent bike or something like that, enough movement is some work there. Or of course you could do it walking like over ground. I've had them have to walk backwards. I mean, you just really definitely do a lot with it, right?
Even in like a hospital setting, if you have like a single foot propulsion patient, I'll sometimes do like a little bit of resistance on the wheelchair if they're quickly propulsion, like doing walking propulsion in the wheelchair, so that they're getting their heart rate up, and then asking them like, name what are the different, how many doors are we passing, or like you're constantly getting them. Think of it as like what you would do for a visual field cut, right? You're constantly trying to get them to turn their head into different areas. So in that aspect of trying to add head movement to intensity and functional movements, the ideas are endless in just about any setting that you're in. So I'm going to transition into this case. This will present just like a stroke. This particular patient had 2 brain tumor resections. And so clinically, it's very similar to a stroke presentation. He has right hemiparesis. He was just discharged from traditional PT, I guess, if you would, non-vestibular PT. And because he was walking independently. And I think that this is really, really in chronic stroke where vestibular rehab has a huge role, because a lot of these patients, the goal is walk independently. Like right then early in stroke, there's a lot to focus on from a mobility standpoint and getting them home and independent. And then it's like, okay, you can walk 150 feet by yourself, have a nice life. Like that's not life. Doing a 6-minute walk test is fantastic, especially if you can increase the distance. But how does that carry over into their everyday life when they're turning from room to room, constantly bending over to pick things up, reaching up, getting dressed, talking to somebody next to them? And that's where the stability piece starts to come in some of those later stages of rehab, where a lot of our focus at that point then is on stability. And that's where I really hit the vestibular rehab hard from a chronic stroke standpoint. And so he had just been discharged because he could walk by himself, but he hadn't met any of his own personal goals. He used to be an avid hiker. He was a runner. He kayaked, and he felt like he couldn't even balance a boat, let alone kayak in one. And so he was really struggling with multi-directional movements and uneven surfaces. Like the thought of hiking is just so scary. And so where do we go from there? You have someone who can walk independently. They're back to driving. They still have a mild right hemiparesis. And so, we spent a lot of time initially just working on speed, because that was a goal for him to return to running. And so this is just to give you an idea of like what his baseline is. He has a couple of right toe drags from that hemiparesis. His right arms gives him a lot of problems. He's got some scapular winging still from the weakness. And so like, where do we go from here? So here's just starting out. Again, low tech. I'm just doing some coordination stuff, but in his peripheral visual field. So he's having to dual task, which is important in this population, as well as reach 2 targets that are in his periphery, which encourage that head movement. And I think a lot of times we tend to work horizontally, but I love diagonally. I feel like so many people have difficulty with this diagonal movement because think it's the plane of the anterior and posterior canals.
Yep.
And I think so many people miss diagonal, and I'm like, do diagonal. Almost
yes,
do it
please.
first.
Well, no, I mean, I think you want to, get them used to the activity. But yes, diagonal, please. Yes.
Yes. And so here I'm using those Spottic cards again, but now I've really increased his range that he's going to have to turn his head. So he's got one card on the treadmill and I'm holding the other one in his hand. He's way taller than me, so I'm trying to get it up there, but I'm only so tall. And you can see when he does this, he starts to trip a lot more over that hemiparetic limb. His toes starting to drag, he's veering, walking off the treadmill at times. You can obviously do all of this over ground. It's just easier to manage with the harness and everything on the treadmill.
Right.
Plus, you only have so much space in a clinic to walk. So he actually struggles more with leftward head movement. So some people will have a directional preference. And from a vestibular rehab standpoint, if you can find that, there he goes tripping. If you can find that thing that's most challenging for them from a loss of balance standpoint, that's where you focus. You really want to like nail into that. So this is just a document that I created in Word with a bunch of E's, and they're all facing different directions. So it's a gaze stability exercise. So you can start on the first E, the eyes stay focused on it, and you move your head one time the direction the E is open towards. So if I'm on the first E, I'm looking at it, I'm going to move my head right once. I take my eyes, to the next E, move my head left, and I can just go down the page looking at the E's and going from E to E. It creates a little bit of variability in the head movement instead of just doing this. It makes them focus a lot on the target, which is good for gaze stabilization, because if they lose it, they lose their place. They're like, where was I on this page? So they really are, they want to really focus because they're like, I don't want to lose my place. So it just encourages the greater variation in head movement as well as gaze stability as they're moving their head. And so this is just him doing that.
Yeah, and I think people are going to probably look at this conversation and say, okay, well, what if the patient is, major field cut, really basically blind? I have a patient who they did not have a stroke, but they have other physical limitations, I'll say, and they are essentially blind. Like they can see shadow, like they kind of know where shapes are, and they probably won't run into something. But that's it. So, my ability to use targets and that sort of thing is limited. So the good news is many functional movements can still be driven, even without as much visual input. So, I have him doing, he likes to joke, he loves to hate me and hates to love me. It's like, so I can have him, for example, do like he can use the edge of a mat table nice and sturdy. I'll have him walk his feet out, and so it's like a modified burpee almost. Like he'll kind of go into that. I'll have him hop his feet forward, plant them, feel where he is. We do a lot of somatosensory tuning in because he's got that, right? And then he'll kind of do a little vertical mini, like I won't call it a jump, but like yeah. So we're getting kind of some vestibular up downs, for example. If I want to get turning going, easy peasy, I put a bunch of cones out on the table, and he just kind of feels. He kind of can know their shape. Grab one. I mean, not going by color here. That's out. So it's just any cone will do. He has to feel them and stack them. Like he's used to using, even though he wasn't born blind, he has lost his vision long enough ago. He's gotten really good. You know what I mean? He kind of like cognitively has figured that out, and luckily he's great cognitively actually. So like I can really kind of rely on him to be like, okay, like. I try to get him to figure it out. I do some cueing, but I'm setting up the task to get the movement I want. And I think you're kind of describing that with how you set up your E's. But the idea is that, there's really there's certainly patients that are limited enough that you're more challenged on what you can do, but you can get creative and work around a lot of limitations, I'll say. Cognition is probably the hardest one, or attention, if they really are limited there, that's gonna just not that it's impossible to do stuff, but it definitely changes what you can do. But otherwise, if they can follow some directions, you got this.
Yeah. I know Dr. Platt's doing a lot of research in, Alzheimer's and cognitive impairment, and how do we do these kinds of exercises in that population. And it doesn't have to be complicated, right? I think she sometimes will take like the TV and you put a patient in front and you're pivoting the wheelchair and they just want to watch TV, right? Like, so you can get creative in how you want to. It's all about motivation, I think.
Yep.
What motivates your patients, what's important to them, and how can you take those motivators and put them into that clinical setting to drive really behind the scenes what you're trying to accomplish.
Yeah, right.
They don't always understand what the point is. You want to educate as much as you can, but it's not a simple thing to explain to people, especially with cognitive impairment. And so a lot of times I think I have secret intentions behind what I'm doing on the outside. It just fun and games, but there's a lot of intention about what you're selecting to try and drive the movements you're wanting them to do with their head or eyes or body.
Right. Absolutely.
Okay. So here I'm just making it a little bit more challenging by having them look at targets every once in a while. So here's one you could do with someone who's lower cognitive, with cognitive impairment. This is just a head laser and it's a light. It's like I almost feel like I'm playing like a laser game with a cat, but they're basically just walking and they're searching around the room for the light, trying to find it. And you can put the light on the ceiling, on the floor, next to them. And they're just trying to visually scan. You can count objects in a clinic. If you have a big clinic, how many people are in here? How many computers are in here? How many ceiling tiles are there, depending on their balance? That one's kind of hard.
Yeah.
How many picture frames are on the wall? Like so many different ways to challenge head movement.
Yes. And a moving light is great because we're evolutionarily driven to attend to like movement in the periphery. I read this a while ago. It's like a safety thing, right? Like, oh shoot, there's a tiger over there kind of thing. So the idea is that if you're able to kind of introduce, I mean, a moving light is just a way to do it. I guess there's some other, like people use balls and things, but the idea is that like that is definitely a way to get attention. So if you have someone with attentional deficits, sometimes that could be effective. With people who have whether it's brain injury, concussion, there's a kind of a line between too much stimulation, of course. So you have to kind of figure out what that looks like. And I actually have a patient right now who has significant autism developmental type issues, but they're an adult, so they can't see a peds PT. So I get to become that a little bit. But he uses his communication board. He has an aid, and that's great. And I'm able to do quite a bit of, all right, I just want to get him stronger. Okay, I'm going to, again, task-based. We're going to pick up weights. We're going to put him in this, like, it's like my step that I flip upside down. That's like a box, and they carry, like, so you can really kind of just, again, even with communication issues, etc., say, okay, what's something that resonates? Like, this person has helped his parents, like, pack up boxes and move. So, like, that has some relevance. So we could work on, some joint stability, and sometimes I can put weights on the wrists, to give additional strengthening, but also to give more sensory input. I know different people do different weighting strategies as well. So just, really kind of continuing to open your mind, whether there's kind of visual input, or do I want to reduce like visual distraction, or kind of what's your goals and what do you kind of need to hone in on, right?
Right. Yeah. And so, so far we talked a lot about like visual tracking and gaze stability, but there's also a lot of just intentional turning, bending, looking up. He's pretty high level. So finding a way to challenge him, I do turning on the treadmill. This isn't for everybody. You can do this over ground, right? I do like every 3 steps, do a 180-degree turn. So you're stepping over ground, sidestepping 3 steps, turn around, sidestep 3 steps. So you're getting a lot of turns and multi-directional stepping. He does it on the treadmill, which is you really start to see when he turns right towards his hemiparetic side, that is a balance challenge and a motor coordination challenge, right? We're working multiple things here. But he gets it. And with repetition, he loses his balance less, and he can actually progress the speed as we go. And I think it's fun for these patients to see what they can do. Like, this is nothing they would try on their own. But it's very rewarding to show people what they're capable of when they're
Yes.
in a safety harness and challenged to do so.
And it's so good for the body to get in positions that they're not used to being in. So whether that's walking backwards, which there's lots of literature on how that's relevant to balance, and it's great to work on for multiple reasons, not just balance, but even like strengthening glutes and so forth. And then also like patients who have literally not gone on their, even laying on their side or laying on their stomach, God forbid, or I like to, of course, go back to the good old neuro positions. If we can get hands and knees, they go, oh, my knees, I can't take it. No, I think you could do it just for a minute if I put this pad underneath you, but it's really neurologically stimulating. I just see it. Like, you can just see, like, with weight bearing on the arms, again, doing that modified position I did with the kind of, I call it the half plank or whatever, you know what I mean? Like, just getting your patients in different positions, and then having my patient that I mentioned, with limited vision, get into the half plank, and then to do like a little work there, reaching there, like, gosh, that's loading the upper body, that's working on core, that's, like changing, again, balance in a way, because who like usually leans forward, and even though these are supported, and then of course vestibular wise, it's a totally different position, and then, kind of to work in that plane, right?
Yes, I try and get everybody in quadruped. The next case, there's going to be a lot of floor work. But, little tidbit of maybe helping those lower level patients where you're like, can I get them into tall kneeling, get them into quadruped? Something that I had kind of picked up on earlier in practice and really like is if you have, a plinth or a high-low table that you can get at about, waist height, and then get a step, and I put a foam pad over that step, and they actually go from standing to kneeling on the step with their hands on the plinth. That is such an easier transition for people to get in and out of tall kneeling. And then you can lower the plinth to then give them into more of a quadruped position where you as a therapist feel safe, they feel safe. It's much easier sometimes than getting like on the floor, or it can be very challenging to go all the way from prone to quadruped as well. And so just like inching into it on, almost like a modified stair step.
No, I love that. Yeah, absolutely.
So that's kind of been a way in some acute care and inpatient rehab settings that I've been in, and in some outpatient too that have more challenging times with mobility. Okay, so then just a little bit of standing. I don't do a lot of standing, but so he's on a compliant surface, obviously to increase vestibular integration. And we're doing the ball toss intentionally high to get head movement for tracking. And then this ball has letters written all over it. It's just like a playground ball you can buy from a store. Has letters on with a permanent marker I wrote on it. And so as the ball is in flight, they are trying to pick out a letter that they see. And so they're calling out A or whatever. And so they're getting the head movement, but they also have to visually stabilize on that ball to try and pick out the letter. And so patients actually have a lot of fun with this one. You can go even more creative from a dual task standpoint, where it's like, okay, name a vegetable with the letter that you see or whatever, for like some higher level concussion patients that might need more of a cognitive challenge. And then this is just another progression on vestibular integration. So this is just a rocker board. So he's trying to keep it flat. It'll let him rock forward and backwards. And then again, trying to drive intensity, something that's harder. So this is a 15-pound weighted ball. You could do it with a lighter ball for somebody who this would be challenging for, but he's pretty strong, and we're trying to really work on that shoulder girdle strength and the scapular winging I mentioned. So he's drawing the alphabet on the wobble board. So it really challenges, almost like a perturbation when they're trying to, the size of the alphabet makes it harder. So the larger the letters, the more perturbation he's going to get from that weighted ball. You can have them watch the ball, so they're getting more head movement on the situation. Really whatever is tailored to that person's challenge point, right? All of these things can be progressed to be to right before their challenge point, like right before failure. Like, how hard can I push them before they actually are going to fall off that board? But they can all be regressed if they're too challenging for people. And so just finding the right difficulty for that person. And this is kind of a whole body work, again, working on the scapular winging, but making sure instead of just doing arm movement, I'm doing full body rotation. So his head is moving as well and rotating as well as we get in some upper body strengthening. And so just being intentional about, I think it's the underlying vestibular therapist in me, but I'm always asking, like, how can I move his head? How can I move their head? How can I move their head? And in everything that I do. And again, we talked about getting on the floor. And so here is just up, downs, getting forward, backwards, walking in. He's trying to go fast, so you're pushing speed, and then back all the way up, down to the ground again. I think floor transfers are functionally very important, but they're also great for the vestibular system to be transitioning from high to low like that. Most people, when they lose their balance doing a floor transfer, it's on the way up, right? Like they get up and they're like, whoa, and he is going to do the same thing. You know, he can walk independently, but that last transition, it's like, whoa, okay, now I got it. And so repetitively working on that up-down movement, I think is really important in every neurodiagnosis, right? We need to be getting these patients on the floor. So let's see. Here we are with the weighted ball again on the treadmill, only adding more head movement. So he's passing the ball to me. I'm having to walk around the treadmill. I think it's more of an exercise for me than it's for him. But, you know, trying to really encourage weighted rotation of the head and making sure he's staying balanced while doing a dynamic task like walking. And then let's see. And then just to plug in this population, like we're always talk about move your head and gaze stabilization, but I think the vestibular system also detects loss of balance. And so it's not only keeping our balance, but it's recognizing when we are thrown off to activate those stepping responses and hip strategies and ankle strategies to then recover. And so perturbation training, slip and trip training is so important across the spectrum of neurodiagnosis, across geriatric population for fall prevention. And I look at that as a vestibular exercise. Here we talk about trips and slip training. I'm just literally trying to trip him as he's walking, which is more fun for me than him probably.
Definitely.
But it encourages, you know, it builds confidence when they're like, she tried to make me fall over and she couldn't do it, right? And it really increases that ABC skill when they recognize what they can do.
Yeah.
So, okay, let's go into this Parkinson's case. This is going to give us a little bit different kind of level. And so this particular patient, 83 years old, 10-year history of Parkinson's disease. 6 months ago, he had a sudden onset of labyrinthitis. So now you have Parkinson's and labyrinthitis, full left hearing loss, very, very dizzy. He had just finished a session of vestibular rehab, but was discharged due to insurance authorization and lack of progress. So we did 8 visits with a vestibular therapist, which was all standing or sitting, gaze stabilization, static standing on surfaces with eyes closed and eyes open, and then overground, you know, walking forward, backwards, walking with head movement and obstacle courses. So you're pretty like traditional exercise, I think, program for vestibular. But I think it doesn't address the Parkinson's. And so he was still dizzy. He still felt off balance. And, you know, I would ask him, like, did you ever feel like your heart rate was up? And he's like, no, I never had my heart rate up. It was a lot of like, go walk, get a little dizzy, sit down, get a little dizzy, sit down. And so not a lot of dynamic balance movements, just like standing and walking, maybe stepping over some obstacles. Another kind of red flag that I kind of noticed from a vestibular standpoint is that since the onset of the labyrinthitis, he had been on meclizine twice a day for 6 months. And so we have an underlying Parkinson's, we have a labyrinthitis, he's 83, and he's been a chronic meclizine user now. And so the vestibular system is like begging to be turned on. I think
Yeah,
like turn
yeah,
me on.
yeah. So to remind everybody, the meclizine conversation needs to be had. To remind everybody out there, meclizine is a medication with a good purpose. Its purpose is to suppress the vestibular system. So if someone is in a very acute dizziness situation, very new cerebellar stroke, that day, right now I'm having a neuritis attack. Like, yes, it's like acute pain. Like, I just broke my arm. Yes, we should give pain medicine because this is like brand new and needs to like be just kind of survived. When we are out of that, when I come from a dizziness standpoint, so we're a couple days out from our neuritis, we're say a couple days, probably 3-4 days perhaps, depending on how bad the stroke was, from our kind of acute onset of the cerebellar stroke or what have you, very, very dizzy. Okay, that's like settling a bit. We're not feeling great, but we're getting there. It's recommended in the literature to wean off or completely get off of meclizine because the brain can't really do a great job of starting to help, kind of to adapt, to compensate, whatever you want to, 100 terms out there. I don't even care. It make changes. The brain cannot make changes very well when things are kind of suppressed, basically. So this is what Dr. Christine is talking about. She's saying, hey, this person's been on meclizine for 6 months. There are exceptions. I think Meniere's is a potential exception. Someone's going through an acute episode, and these episodes happen from time to time. And again, they just need to be survived, for that kind of 12 to 24 hours or whatever it is. You know what I'm saying? So like, I'm not saying meclizine does not have a purpose, but unfortunately, many doctors have been trained that this is what we do to help with dizziness, which I guess if you had no vestibular rehab, maybe better than nothing. I don't know. That could be argued, but I think there's a lot of literature that's basically come to the forefront to say, the best recommendation is most people should not be on a standing dose, like where you take it every day. Some people should have a kind of as needed. Again, that Meniere's patient is an example where if it helps to kind of survive an episode of Meniere's, okay. So it's very difficult to really get rid of chronic dizziness when you're on it. I think that's fair to say. All right, I'm done. Go.
Well said. Okay.
And never for BPPV, basically.
Never. Thank you.
Maneuver, clear that sucker, and let's go on.
Yeah. Yes. And so my treatment plan wanted to mesh this neuro rehab approach of high intensity, functional, large amplitude movements that we typically use in Parkinson's with his dizzy triggers, right? He was dizzy at baseline, but he really was dizzy when he turned over, or like turning around, not in bed, but just in everyday life, and then bending over. He felt really unstable on grass and in the fields, and he owned a farm. And so like, we need to be able to get him out in the field. And then obviously adding in some gaze stabilization where we could in these movements, not spending a lot of time on just isolated gaze stabilization, but let's integrate it into some of the stuff that we're doing. So this is just an idea of his baseline when he came in, and you can see some of the fascinating with turning. He can get up and go pretty quickly once he turns, but again, sometimes dual tasking would be a problem. And so we started on the treadmill. There's some research out there in neurologic patients about neural priming. So trying to start the session with an aerobic exercise that's going to raise heart rate, release some good endorphins in the brain that are going to help drive neuroplasticity. And so in this particular patient, we really tried to start every single session with at least 5 to 10 minutes of high intensity treadmill work to get his heart rate up. This is a really fun one. If you have someone with visual vertigo, so you turn the treadmill off and they're propelling it with their feet. This is going to really drive intensity and heart rate, but the treadmill moving and their vision can be very, very dizzy provoking. So that was not the purpose for him, but just a plug, if you have someone with visual vertigo, they'll watch their feet step as the treadmill runs, and they're like, "Ooh, this is a habituation exercise. Why we drive intensity." So we talked a little bit about backwards walking. We did a lot of backwards walking with him and sidestepping, lots of multiple directions. You can do this over ground. I typically use the treadmill just because that's where my harness is, and I can get most steps in that way. Here he's doing that same turning we saw before. It's a little bit slower. He has to hold on. This really helps train some freezing as well in Parkinson's, because in practicing these repeated turns can help reduce some of the freezing that they get that you see with turning, as well as getting lots of turns in the session, right? His head is turning and turning and turning. And you're froze. There we go. So here we're going to combine a couple of things. We get head rotation, and you can see whenever he turns his head, he veers or he has a loss of balance to the side. So I'm going to have him hold on just so that we can get the head movement in while he's still doing a walking exercise. So for him, he needs to hold on with one hand to do this. Now let him get his steps. Like I'm trying to cue him to do larger steps, get back into the flow. Okay, now we're going to try another head movement. And this can be done with VOR cancellation. So for him, that's too much. It's just literally trying to grab a card and put it in the cup holder on the other side of the treadmill. So we get a functional reach and rotation, the head's moving, he's trying to balance. In a patient that does this really well, I add VOR cancellation to that turn. So they're trying to keep that target and focus as they turn. We talk a lot about functional strengthening in this population. Sit to stands, I think, is everybody's go-to because it's easy, it's functional, it works. And so here's kind of a lot of different ways that you could do that to add some head movement, add some challenge, and increase your variability in how you're training. So in Parkinson's, we talk about large amplitude, and these poles allow for a large amplitude arm movement as they sit to stand. It also allows patients to bend forward more. So you can tend to get a lot more head bending down and movement in a sit to stand when you do these different types of interventions during your sit to stand. Here we're doing upper arm heavy work, but you can see how much more forward he gets his head because the weights make him feel stable. He has to bend forward to pick these weights up. Mm-hmm. And so we can get a lot more head movement and functional strengthening out of a sit to stand when I just add an object to it. It doesn't have to be heavy if that's too much for them. He does really well with it. So there's lots of different objects you can place in front of somebody to encourage a forward lean and up. Here's that same weighted ball, so 15 pounds, and we're gonna do a sit to stand with it all the way, stand and then slam it down. He's bending over to pick it up. So we're getting that repetitive bending. This is very therapeutic for him, I think, from a mental health standpoint. He loves slamming this ball at the ground.
That's what exercise is for, baby.
Yeah. That and boxing. Boxing is good too. There's some of that to come.
Yeah, that's good too.
Yeah. So there's a lot of bending involved here, which bending was one of his triggers. So how can I make it functional, address the bending, but add some heavy work to drive the intensity and strengthening? And so here we're doing that same kind of ball slam and toss with a pickup, but adding some walking to it. So taking it further and creating some more dynamic movement with those exercises. So he's turning, sits down, stand up, and then throw it as hard as you can, go bend over, pick it up, and come back. And so that adds a sit to stand, a bend, a 180-degree turn, and walking. It's a lot of vestibular movement, but very functional, and his heart rate was up.
Yes, and I know it's tempting to do as much standing and walking as possible. I know there's folks who are like, oh my gosh, my patient can hardly stand, etc. I have a patient today, they have a lot of orthopedic issues primarily, and their balance and gait is pretty impaired. And so they're in their late 80s, we'll say. So there's a lot there, body kind of status wise, we'll say. So, we did certainly our share of standing and walking work, but towards the end, there's definitely some fatigue factor. We got to think about safety. So I had him sitting at the edge of the mat table, and I've got kind of a medium weighted ball. It's like 4.5 pounds. And I was able to toss it, and he could catch it. He loves baseball. So I'm like, you're not going to get to play for the Phillies if you don't get this ball. So I'm tossing it to his kind of right and left alternating way. So we're getting some nice vestibular because it's just automatically with the weight of the ball, it kind of would pull him a bit, and then he's working his core. You know what I'm saying? So like, I just feel like even in those times where you're like, oh gosh, like I don't know, I can squeeze much more out of this, hour or 45 minutes, whatever you folks get with your patients, like, it's okay to like kind of say, okay, like let's switch gears, even though I love the standing and walking, that you can't necessarily with every patient, certainly at the beginning when you're starting out with them, like that's not necessarily even realistic, right? To like, so know that there's seated work, and if he didn't have enough balance to sit without support, there's a way to do it with support, or maybe like light support, or you know what I mean? Like, right?
All of these things could be done, like all the stuff on the treadmill with rotating with the heavy ball, looking at fingers, finding a light, all of that stuff could be done all the way down to sitting. So you can take any of those, stimulus, if you will, to try and activate or encourage head movement and do it at any level.
Actually, you can do it laying down. Right?
You
Because you can make them roll if that's a possibility for them. I mean, rolling is great. Like having to come onto kind of reaching to one side or the other side, right? That's vestibular stim too. Lest us forget.
Yes. So this is just more forward. I'm really trying to figure out how can I get his head down, forward bending, because that was a big trigger for him. So we're getting a little bit of an ab workout in the mix as well.
Yeah. And I think some people say too, like, oh my gosh, the movement's provoking, they're going to resist it, or, kind of this idea of habituation. And so you mentioned already kind of guiding the amount of how much symptom will let elevate. And I think the patient certainly can kind of set the tone for what I want that to look like. If I have a very, very symptomatic, again, post-concussion in particular, more what I call a sensitive patient, migraine is involved, I won't go above a 2 unit increase on symptoms for that group, because they tend to kind of elevate and kind